privilege to introduce Dr. Neil Mehta for the next talk about updates in the management of HCC. Neil is currently as clinical assistant professor at UCSF. Neil completed his GI fellowship and training at UCSF and has been there since 2013. Neil's interests are in management of HCC. His core interests are in predicting risk scores for dropout from the transplant list and also predicting recurrence risk scores for the recurrence of HCC after transplant. He's also interested in management of alcoholic liver disease and recidivism after liver transplant. He's been keynote speaker in several societies, including recent AASLD in 2017 and 18 also. In recent Spanish Liver Transplant Society, he was the keynote speaker in Valencia. So I'm going to invite Neil to give our next talk here. Thank you for coming.
Thank you. It's a very nice introduction. All right, so kind of continuing the theme of case presentations, I was hoping to go through an HCC case that just came through, and the story is not yet finished, but I wanted to kind of tell you what we've been up to with this patient. So this is a 51-year-old man with presumed alcoholic cirrhosis complicated by multifocal HCC who presented for an initial transplant evaluation in February. He was first diagnosed with cirrhosis in October of 2014, and at that time he had presented with a variceal bleed and underwent band ligation over several sessions, and that's when he quit alcohol. And he also has notably metabolic risk factors, including obesity, though he's been able to, his BMI has gone from 48 to 36 with diet alone. In terms of complications, he's had intermittent mild encephalopathy in the past and takes rifaximin occasionally. He also has some mild edema and ascites, so he's on Lasix and aldactone, doing well with that. In terms of his HCC presentation, he had a CT scan in January that showed 2 lesions. Both were sizable, 5.5 centimeters at the dome with possible washout, and 3.5 centimeters in segment 8 with subtle washout. When we kind of go back through the records, it sounds like they may have actually seen a larger lesion back on the scan before that, where it measured about 3.7 centimeters. But his AFP has always been normal. So he has alcoholic cirrhosis with encephalopathy, ascites, and varices. In addition to his HCC, he has obesity, osteoarthritis, sleep apnea, and vitamin D deficiency. He has no surgeries. His medications, I've mentioned all of these. He's also on Nadolol, I should say. And then we do, on the day of his initial transplant eval, this is his full social history. He's married. He has no children. He lives nearby, about an hour from San Francisco, with his wife, who'd be his primary caregiver. He owns a trucking business. He used to chew tobacco, quit about a year before he came to see us. He has former heavy alcohol abuse, typically about 4 to 6 drinks a day, but quit, as I mentioned, in 2014. And he's deemed a low-risk candidate from a psychosocial perspective. On exam, pressure is 90s over 50s, pulse is 65, his BMI is 37, oxygen saturation is okay. He looks robust. No volume overload, no fluid wave, his mental status is normal, as is his psychiatric exam. Here's his labs. His bilirubin's 2.4, 50% is direct. INR is 1.5, sodium's 132, creatinine's normal, albumin's 3.3, and his MELD is 16. His white count's 2.6, his hematocrit's 40, and his platelets are 49. And then we get tumor markers. AFP is normal, as I mentioned. His L3 fraction is 12%, which is just slightly above the reference or the normal, upper limit of normal. And his DCP, this other tumor marker that we measure, is about twice the upper limit of normal at 15. He's blood type O, and his UTOX and ethyl glucuronide and sulfate are negative. So we get an MRI just a few days after initial transplant evaluation. And he's noted to have 2 lesions. One is 5.5 centimeters at the dome, and the second one is more ill-defined. I'm going to try to show you pictures. They didn't come out a little bit more ill-defined, but both have washout. Both are deemed LIRADS 5. And then he also has splenomegaly. He has evidence of portal hypertension as well with varices and ascites. And then he has chronic partial occlusion of the portal vein and SMV, and then thrombus in the splenic vein as well. So this didn't come out too great, but you can see here in the dome, that's not coming. Let's see, does this work? Yeah, cool. So you can see this 5.5 centimeter lesion at the dome, and then a little bit more ill-defined lesion in segment 8, 4.5 centimeters. and both of these do have washout. And so when we think about transplant criteria, this is now kind of standard, I'll say at least region-wide, if not necessarily nationwide. So the Milan criteria is nationwide. This is what you have to be in to get MELD exception or extra points for transplant. So either a single lesion up to 5 centimeters, 2 to 3 lesions up to 3 centimeters, and no extra hepatic disease. Now the Region 5, which includes California, our downstaging criteria is now a national policy. So, and I'll come back to this in a second, but these are patients who are just beyond Milan criteria. So patients who have a single lesion, it can be up to 8 centimeters. Patients who have 2 to 3 lesions, up to 5 centimeters. It also allows for patients to have more than 3 lesions up to 3 centimeters. But when you sum the total tumor diameter, it can't be greater than 8 centimeters. This is national policy. We'll come back to this. All right, and then if you're beyond that, we call these patients all comers. And these patients now do have a pathway to transplant in our region and Region 5. This is recently our Region 5 review board. When we go to a national liver review board soon, it's yet to be seen what the pathway for these patients are going to be to transplant. But if you're in UNOS downstaging and you go to Milan, then you can get points. And in Region 5, if you're in all comers, which is any number of tumors with a total tumor diameter over 8 centimeters, you can also get points if you're downstaged to within Milan criteria. So in summary, we have a patient who's Child-Pugh B9 or C10. He's MELD 16, he's decompensated. He has 2 lesions with a total tumor diameter of 10 centimeters, putting him in all comers, and his AAP is normal. And so the question really becomes, and the question for us and now for you all, is what are the treatment options? What can we offer this gentleman, going forward? Local therapies. Anyone in particular, Mikhail, that you would advocate for? Or? Yeah, if you're doing is there one that you might say, yeah, let's do that one. It seems to be a good option for him. Okay, all right.
I would worry about a lot of them with these child C, and I would start to ask questions about things like SBRT and other non-standard modalities.
Yeah, perfect. So SBRT, external radiation, we'll come back to in a second, but maybe some of the therapies that are less likely to cause him to decompensate, but still may be effective to get him downstage. So I think that's a good idea. In that list, we kind of think of SBRT, and I guess ethanol is still kind of on that list, though it's kind of hard to know how, these lesions are pretty big and how effective ethanol is. But we, I think SBRT option probably would have to treat, the lesions are far enough apart, you probably have to treat them separately over 3 to 5 sessions each, but that's a really good option, I think. Yeah, so Y90 we're going to talk about in a second. Typically good for big tumor burden, so we like Y90 a lot. We'll come back to that concept. So when we're thinking about all these different modalities, so you all mentioned local regional therapies. It's a couple of things that we don't typically do it, in our region or nationally is kind of to go immediate to live donor transplant, though certainly in other countries they might just transplant this patient if they have a live donor. And then some places a lot of people would just skip local regional therapy altogether, say the patient's too sick, and maybe go straight to, they're almost certainly too sick for chemotherapy, right? B9, C10, Child-Pugh disease, but maybe they might go to an immunotherapy or something along those lines. So there's a lot of options, but, we're a transplant hepatologist. We like to try to get someone to transplant. So we try to downstage them, so that's a reduction in the size of tumor using local regional therapies to meet acceptable criteria for transplant. And it's important that when we measure the response, we're only measuring viable tumor. I'll show you a picture of this in a second. So you don't want to include the area of necrosis because then it's going to look like you haven't accomplished anything at all when you look at just size alone. And the really nice thing about downstaging is that it really can function as a selection tool. So if you have a patient, this patient for example, and you try to treat the larger lesion, and the next scan, it's doubled in size or there's new lesions, that's probably not someone who's going to do well with transplant. But if they have a favorable response, a complete response or partial response, that is someone who may do well with transplant. So this is a different patient, not our patient, but this is a relatively high dome lesion that's presenting beyond Milan, and then you treat them. I'm not sure exactly which treatment this patient got, but now this looks dead. We don't measure that. You only measure this size. Now they're within Milan. You treat them again, and now they have complete necrosis. So this patient is beyond Milan. Now they've been downstaged, and now they have a complete response. So you mentioned most of these. So transarterial chemoembolization is, at least at UCSF, and I know a lot of centers, is the mainstay of local regional therapies. We briefly mentioned ethanol. It's largely been replaced by ablation. Radiofrequency ablation can be done laparoscopically or percutaneously. And then now more and more places are, instead of using RFA, they're more using kind of microwave or cryoablation. we don't have enough time to really get into the specifics of different types of thermal therapy, but we tend to use ablation for smaller lesions. It's really hard to ablate a 4 or 5 centimeter tumor. But if you have a single lesion, 1.5 to 2.5 centimeters, ablation can be a really, really good option, and can also, in a minority of instances, can be curative. And then we mentioned the radioembolization or yttrium-90, and then external beam irradiation that Will mentioned. So I just want to just take one slide on Y90, since not all of us know too much about it, but you're going to see more and more of it as time goes on. So it can be delivered as either glass microspheres, which is theraspheres, or resin microspheres, which is serospheres. And radiographic response rates are really, really good with Y90. But unfortunately, the survival benefit is, since it's relatively new, it's only been around for 7-10 years, the complete survival benefit is kind of unknown, especially related to things like ablation or TACE. And certainly there is a risk of radiation damage. So we mentioned Y90 may be appropriate in this patient. A lot of centers use a bilirubin cutoff of 2 for Y90. So patients who have advanced tumor stage, patients who have who are really decompensated with a high bilirubin may not be appropriate for Y90. I think that kind of people are starting to rethink that bilirubin at 2 cutoff. I know Northwestern now is starting to do kind of people with a bilirubin at 2.5, like our patient has a bilirubin at 2.4. But some centers do still adhere to that cutoff. So I think it's important to know, is your patient going from a bilirubin of 1 to 2.5, or are they going to 2.5 to 2.5? That patient may be the one that Y90 may be fine for. So this is, again, not our patient, but another patient, Y90 with theraspheres. So you can see on angiogram, so Y90 is done over 2 sessions. So a planning angio, where you do the angiogram and see how much shunt they have, what their shunt fraction is. Because if they're putting too much of that radiation into their lungs, for example, that's probably not safe to administer radiation. And then they come back for the actual treatment itself. Most centers have to do that over 2 different days rather than on the same day. So this patient, before they're treated, you can see they're kind of bilobe tumor. 1 month after their first treatment, you can see you have a lot of necrosis in both parts of this tumor. And then they now undergo a second treatment, and now you can see that most of it actually looks dead. So this would be a really nice response to a really large tumor. There's only been one randomized controlled trial that's ever been done to evaluate Y90 versus TACE. This is the Premier trial that was published in Gastro 2 years ago. This was a very small trial. As you can see, this was 21 patients. Well, they tried for 25 and 25, but they lost a few, but 21 and 24, and so 45 patients total. But clearly important enough kind of to think about that I got into gastro. So they looked at 2 important things: time to progression, okay, for after the treatment. You can see here that the Y90 arm did much, much better in terms of time to tumor progression compared to the conventional TACE arm. It's also interesting they compared it to conventional TACE. Probably a lot of you know now that we're doing a lot more doxorubicin-eluting bead DEB TACE rather than conventional TACE, but that's what they did in this trial. And you can see that there's quite a difference in time to progression. Y90 did better, but the issue is that intentional treat survival between the 2 arms was exactly the same. And the authors know this. They know that you'd have to have a much, much, much larger trial to potentially see a survival benefit. But time to progression is an important oncologic endpoint, and so I think the jury is certainly still out. We tend to like Y90 for really large tumors, bilirubin, as I mentioned, under 2, 2.5. So going back to our transplant criteria, what's our data that we have about people who are beyond Milan? So in terms of downstaging, this is data that's combined from Scripps and UCSF and CPMC, where we took almost about 200 patients and enrolled them in a multi-center prospective downstaging study, and we saw very good patients who made it to transplant had excellent 1 and 5 year post-transplant survival, and so this was part of the data that allowed downstaging to become national policy. And one of the other things that having this many patients allowed us to do was really try to figure out who doesn't benefit from a downstaging approach. Who are patients who really we probably shouldn't be trying to get them to transplant? And so we define treatment failure as basically patients who either didn't make it to transplant or recurred after transplant. And what you can see here is that it wasn't a large group, but if you did happen to have an AFP over 1,000 before your first ever treatment and you were decompensated, you basically were definitely going to be a treatment failure. So it's not going to exclude a lot of patients, but it is a nice start to try to say, okay, who are patients who are appropriate to consider downstaging and who might you not say, maybe this isn't the right way to go. So with all that being said, downstaging has now been accepted as national policy based on the Region 5 downstaging criteria. Patients can drop out before they ever get to Milan. They can drop out after they get to Milan due to tumor progression or liver-related death. We mandate an observation period of at least 3 months. That's to make sure that someone who gets downstage right away, their tumor explodes again. We want to exclude those patients from transplant. So we do have a minimum observation period. And then as they're waiting a transplant, we still offer them local regional therapy if they can tolerate it. And then eventually they get to transplant. And as I mentioned, their 5 years appears to be the same as patients who are always within Milan criteria. What about all comers? So the data isn't as good for all comers. So this is data that one of our residents presented at AASLD, actually almost 2 years ago now, that had about 74 patients in our all-comers group, and we compared them just to UCSF patients who presented within our downstaging criteria that I mentioned. Well, obviously they have more tumor, that's by definition. But the interesting thing here is that about a third of them were never able to be downstaged. But really the key part here is that even if you are able to get downstage this all-comers group, a lot of them then drop out. So if you have a lot of tumor going into it, you're probably not going to make it to transplant. That's kind of what this data says. But what we do like about this data also is it allows us to really try to tell which of the all-comers patients can we get to transplant. And what you can see here is that the larger your tumor burden, so we define this as the number of lesions, this is on imaging, plus the largest tumor diameter. Okay, so the higher that number is, the less chance you're ever going to be able to get that patient to Milan. So we couldn't figure out a definite cutoff where if you have more tumor, you definitely shouldn't even bother. But at least this allows us to start thinking about which of our patients we can get to Milan and eventually get listed. So our patient that we're currently presenting had 2 lesions. The largest was 5.5, so they are 7.5 total. So they're kind of at this blue line. So there's a very good chance we're going to be able to get this patient to Milan. Now, I should say that this is just tumor burden. So this doesn't take into account the fact that our patient is decompensated with a MELD16 and a B9, C10 Child-Pugh patient. So that has to factor into that as well, but this is when you take all the all-comers patients. And then the other important part of this study is that we really showed that, if you're in all-comers, you're not gonna do as well as the downstaging group. So it does seem like there is some sort of tumor burden cutoff by which outcomes really start to get poor when you're thinking about overall survival. So our patient, we actually elected to undergo super selective TACE. We're certainly worried, that they might decompensate, but we didn't really have any obvious live donors. He knew the risks. We did a super selective TACE. And his scan 1 month later showed that the dome lesion they treated actually looked great. It was actually a little bit smaller than before, which is one of the nice things you like to see. But then the other lesion, the segment 8 lesion, was still ill-defined. They actually even started to call it maybe infiltrative in appearance, and we said, uh-oh, and it was almost twice as big as it was 3 months before. So this was really somewhat nerve-wracking to us. And then we also showed that he had chronic occlusion, again, of his main portal vein, SMV, and splenic vein. So one question I have for you is, and this kind of comes up at least for us, but how do you guys think about how do we know if this patient's, with a lot of tumors, actually, is this tumor thrombus or is this bland thrombus? I know often we wait to see what our radiologists say, but any characteristics that you guys think of that clues you into tumor thrombus? You can if you're going to do treatment and they're going to angio. You can see, but I haven't seen a lot of angios that actually are able to diagnose it. But But along those same lines, you can do something called contrast-enhanced ultrasound, which a lot of centers now have, and they do a lot in Asia. And it really is, if you're nervous about tumor thrombus, I think that's often a good idea to be able to see if there is, you can get a better sense if there's tumor in the veins. Any other radiographic criteria? What was that? So you could do, so you certainly could get more imaging. Say we did it and it looks similar. What we recently this Avena criteria, and we studied all of our patients at UCSF into both CT and MRI, and we found 5 criteria that really distinguish bland and tumor portal vein thrombus. We didn't have a ton of patients in the tumor thrombus arm, but the data was pretty good. I'll show you it in a second. But if, in some of these terms you've probably heard before, if the tumor is basically adjacent or contiguous with the thrombus, that's makes you worried for tumor thrombus. If there's enhancement in the thrombus or venous expansion, or if there's neovascularity, those are the 4 imaging criteria. And then also if your AVP is over 1,000, these are the 5 criteria that really suggested tumor thrombus. And our patient had none of these 5 risk factors. And when you look, at this area under the curve data, you can see that probably about 3 risk factors perform the best with really good sensitivity specificity. And so, our patient had none, so can be pretty convinced that we don't have to worry about tumor thrombus. So now we have this patient with the enlarging segment 8 lesion. Now his bili is 3, but his direct bili is only 1.1. AFP is still normal. He tolerated the taste well. Next steps, we kind of already went through this. We actually took up Will on his offer for SBRT. We agreed that maybe that might be the nice thing, to not tip him over the edge, but try to give him some sort of tumor response, especially since he only had 1 lesion that would appear to be viable. So he underwent 3 sessions in July, but actually about 2 months later, hard to know if it was from the SBRT or the natural history of his disease, his bilirubin started to rise, went up to 6. Originally his INR was stable. And so then on October 1st, we got an MRI, so this is just about 2 months ago, that showed extensive ill-defined HCC in the segment 8 lesion with a significant residual enhancing tumor. So we did SBRT, it was about 8 centimeters. Now we see about 6.5 centimeters of tumor. So right within what's called our expanded UCSF criteria, but still beyond Milan. And then a few days later, he decompensates further. His sodium is now 120, his bili is 32, and he has AKI with a creatinine of 2, and his MELD is 35, so he's directly admitted to the hospital. So I guess the question for the group is, should we transplant him? We don't have any time now to decide. He's quite sick. He has what appears to be 6.5 centimeters of tumor left. What do you guys think? Is this someone that we should or shouldn't transplant, or get more information, or? We certainly tried. We were unsuccessful. I think his sodium bumped up a little bit with the standard kind of holding diuretics, and his creatinine may have gotten slightly better, but I don't think his MELD ever got any better than like 32 or something like that.
If you have somebody waiting in the line,
yeah,
you bump that person to get in this person's liver.
That's the question. So that's the issue with the line, right? So the line is, how do you put HCC and non-HCC patients on the same line? And that's always been the real struggle that a lot of smart people are trying to think about. And so far, as you probably know, we just clump them together. We give these patients MELD exception points for HCC, and eventually get to the top of the line, the top of the list. We're trying to redo all those things, and there will be changes to the current policy soon. There's been several iterations over the last 10 years. But it is bring up the concept of urgency, right? So a lot of HCC patients, especially if they're child PUA patients, they don't have a lot of urgency, right? They might have utility, meaning they'll do well with transplant because you're getting rid of the cirrhotic liver, you're getting rid of the cancer. Urgency. This patient actually has urgency. And so it really brings up the concept of transplant survival benefit, right? So now you actually have a patient who is not going to list survival, and has 2 indications for transplant, which is HCC and decompensated liver disease. So I think the concept of a survival benefit is something that we often forget about when we're thinking about transplanting, 73-year-olds with a single 2-centimeter HCC that are well compensated. That's probably not a good use of livers. So these are just things that we like to think about.
Like devil's advocate?
Yeah.
His 2 lesions plus 9, I think you said, or 10 centimeter total. What's his expected outcome if you ignore his decompensation? I'd be pretty worried about that.
Exactly. So do we have any data that can tell us, how he's going to do? And so this is, and you're exactly right. So we have to start thinking about these issues. So he had originally 10 centimeters. Now he seems to have only 1 lesion that's 6.5. So that's kind of where I plotted him on this Metro Ticket 2.0 calculator. I don't know if you've seen this before. This was Mazzaferro, who originally did the Milan criteria, followed that up with something called the up to 7 criteria. And then last year in Gastro published this, which is HCC-specific survival with transplant based on your AFP and your tumor burden. So this is on explant, actually, so we don't know his explant, but if you were going to transplant someone, you sum the number of tumor nodules, the same sum I told you for how we did the all-comers, number of tumor nodules plus the size of the largest nodule. So if we're saying he has 1 lesion that's 6.5 centimeters, I put the X here because his AFP is 2. So actually his HCC-specific survival in this several thousand cohort from Europe is actually pretty good. I don't know if this line is kind of in that 85% plot line. So it's not bad, and it's a little bit better than I think we would have thought if we just said, oh my goodness, this is a lot of tumor. So that's nice, but I think this all kind of plays that we need more information, and so this is what we kind of decided to do with this gentleman. So we repeated his tumor markers, including the DCP and the AL3. I don't know if a lot of you are using these in clinical practice, but you're going to be seeing them more and more as time goes on, I think. But we still don't have a lot of data on how well they do with transplant in terms of do they help us predict dropout or post-transplant outcomes, but a lot more and more centers are using them. So his DCP had risen. Remember, 7.5 is the upper limit of normal, so 38 is quite high. But his L3 is still okay. 10, 15, 16% is probably okay. And what's the data for these? There's only been really one great study that had about, this is from two centers, both part of the Mayo Consortium. This was retrospective. 70% were within Milan, about 15% recurrence. And they only had 127 patients who had these extra tumor markers. And what they found is that you can actually, they thought a combination of AFP and DCP really predicts people who have a really good outcome. So if you have a low AFP, 250 is not a great cutoff, I should tell you, but that's what they picked. But our patient is low AFP in this cutoff and high DCP, and so they do have a higher risk of recurrence, but it's not the highest risk group. So this should give us a little bit of pause. We also decided to do a PET scan on this gentleman, and his PET scan, and we're not looking for extrahepatic disease, we're looking if the tumor itself is metabolically active in the liver, and that's because there's some good data that tells us that if you have a positive PET, meaning that the tumor itself in the liver is metabolically active, has a high SUV, those patients do worse with transplant. So this is data out of Korea. A couple other criteria for transplant include PET as well, but this is kind of the most well-published. They used a combination of total tumor diameter up to 10 centimeters and a negative PET. And patients who fulfill that criteria, which our patient does, do really well with 84% 5-year survival if you're looking at both either tumor or imaging or their explant. They have really good overall survival. So I think PET can be really a nice factor. If this guy was PET positive, I don't think we would have transplanted him. And then what about biopsy? So we don't biopsy a lot of our tumors, but the biopsy does allow us to give some interesting information. And so there's been a couple centers and criteria that use biopsy to help determine if they're going to transplant someone. So probably the best published is the Toronto criteria, published in Hepatology a couple of years ago. And what this criteria is basically you can have any amount of tumor you want, and as long as it's in the liver. But if you have any tumor-related symptoms, you don't get a transplant. And if you have poorly differentiated, if you biopsy, you have to if you're beyond Milan, you have to biopsy the largest tumor. And if you biopsy it and they're poorly differentiated, you're not allowed to go to transplant. So that's the two criteria. And when they do that, they actually have really good, 70% 5-year survival in patients who are beyond Milan, but pretty good actually. So our patient's beyond Milan has no tumor-specific symptoms. And so what if we biopsied him, and if he wasn't poorly differentiated, he probably would do all right. And then recurrence is a little bit higher, as you might expect. But, 30% is not, you could argue is not terrible. And so we actually did biopsy this patient intraoperatively. He was too sick for a kind of a percutaneous biopsy. And it showed well to moderately differentiated HCC. And so when you summarize kind of the selection criteria, when we think about this patient in our head, we see on the good side, low AFP, relatively okay L3 fraction, well to moderately differentiated grade, PET scan's negative. He had a partial response to his local regional therapies, and his wait time is 8 months. I didn't talk about wait time. I don't have too much time to get into it, but basically the idea here is that if you go straight to transplant with someone and you haven't observed their tumor long enough, you may not have enough time to observe a really aggressive tumor that's going to explode after transplant. So, some people say 4 months. A lot of places say 6 months. Now, 6 months is national policy. So every single patient who's trying to get points for HCC has to wait 6 months before they can get 28 MEL points. But on the other side, this patient's beyond Milan, and their DCP is high. So a lot of pros, 2 cons, and we ultimately did decide to transplant this patient on October 13th. You can see here, in terms of the tumors, you had at least 5.5 centimeters of viable tumor, moderately and well-differentiated tumor type. There was no microvascular or macrovascular invasion, fortunately. As you may know, that's probably the best predictor of recurrence post-transplant is microvascular invasion. And there was no tumor, there was no local extension or anything. So on frozen, you can see that this was an HCC. They didn't see any atypical features. There was no concern for mixed cholangio or anything like that. There was some partial necrosis they saw. This was a moderately differentiated tumor type. You can see kind of these large pleomorphic nuclei here and here that if you're the Edmondson criteria we use, well, moderately, poorly differentiated tumor came up in 1960. So we use the same criteria that we used 60 years ago for kind of differentiating tumor types. So a lot of recent scores have tried to make that better, and one of the features they use is kind of how big the nuclei are enlarged, may have a kind of a worse signal. And then almost all HCC, by definition, start to lose reticulin as well. And the patient was cirrhotic, as you know. So there's some many scores that have, well, not a lot, but a couple scores that have come out to predict how this patient's going to do after transplant. And this is kind of important, right? We decided to transplant them, but it's, were we right? We don't really know, but, we can guess. So we use the retreat score, which is a combination of 3 variables. This is a explant score. So you don't use this to figure out who should get a transplant. You use this to figure out how they're going to do after transplant. So his AFP was under 20, so he got no points for AFP. He didn't have microvascular invasion, and his largest viable tumor size plus number of viable lesions was under 10, so he gets 2 points for that. And so actually, when you look at national data in the UNOS database, patients with a retreat score of 2 actually have an 85% 3-year survival, which is pretty good, I would say. Whereas if you're in the retreat score of 4 or 5, you really start to see worse outcomes. So we think our patient hopefully will do well. And then what's his risk of recurrence at 5 years? Probably around only about 11%, which actually I kind of scared you with all the features of this tumor, but it's important to remember that AFP and microvascular invasion are really prognostic. It's not just tumor burden, tumor size that matters. And so, 11% recurrence. So how are we going to manage this patient going forward? For all of our patients with a retreat score of 1 to 3, we do surveillance every 6 months for 2 years. You can see, depending on the retreat score, how we do different surveillance. So if they had a retreat of 0, meaning no viable tumor, normal AFP, no microvascular invasion, we don't surveil them at all. And if they have a retreat score of 5 or higher, they get intensive surveillance for HCC. And the way we do surveillance is with multiphasic abdominal CT or MRI, as well as chest CT and AFP at the recommended interval. And then just, I only have 3 minutes. I just want to finish by talking about, so that's how we're going to do his surveillance moving forward. What about how we're going to manage his immunosuppression moving forward? So standard post-transplant immunosuppression is calcineurin inhibitors, typically tacrolimus or Prograf, along with mycophenolate and prednisone, but it's been postulated that the CNIs can increase HCC recurrence risk. On the other hand, it's been shown in vitro and in animal models that mTOR inhibitors, the mammalian target of rapamycin inhibitors, can regulate cell growth, proliferation, metabolism, and aging, and have shown anti-cancer properties. So a lot of people have been really excited about using mTORs in patients at high risk for cancer recurrence or other types of cancer besides HCC. And it's been shown that mTORs can prevent angiogenesis with VEGF-mediated pathways, so they can limit tumor growth. And they also induce extensive microthrombi, so they can inhibit tumor growth as well. And the mTOR pathway is upregulated in about half of HCCs. We're not yet to just routinely doing mTOR expression on HCCs, but at some point we may start doing that. And so a lot of centers have shifted to using mTOR-based immunosuppression. Patients undergoing transplant, is that the right thing to do? There's been 2 studies on this topic. This is SRTR data, national data that shows that this is retrospective, 4,000 patients, of which only 5% received sirolimus, which is one of the mTORs, the older mTOR. Now we use everolimus mostly. They linked them with national pharmacy claims compared to patients who were never treated with sirolimus. As you might guess, sirolimus patients were more likely to be outside Milan because maybe those are the patients that you say, oh, let's give them sirolimus on. But they didn't see any differences between the groups in all-cause mortality, cancer-specific mortality, and HCC recurrence. So this was a kind of a strike against mTORs. But then really this is the trial. This is the Silver trial. This was a prospective phase 3, multi-center, international randomized controlled trial. And you can see both looking at recurrence-free survival on this slide, sirolimus in red, no sirolimus arm in blue. These are about 250 patients in each arm. There may have been a signal in the first couple of years to improvement in recurrence, but that went away after 5 years. And then also looking at overall survival, again, maybe a signal for a couple of years of having a benefit, but overall, after 4 years, there was no benefit in patients who were treated with sirolimus as opposed to non-sirolimus arms. So kind of our takeaway from this is to consider moving away from studying mTORs in all HCC recipients, but instead focus on those most likely to benefit. Maybe in the future, we might try to target patients who have upregulation of the mTOR pathway. And so maybe we'll start to do molecular subtyping. And then there are ongoing randomized controlled trials of comparing everolimus plus tacrolimus versus mycophenolate plus tacrolimus for transplant patients. And they're going to randomize them based on their tumor factors. So I think that's something that the Silver trial didn't really do very well. But hopefully in the next year or 2 or 3, we'll have more data on how to manage these patients after transplant. What we do at UCSF is if their retreat score is 4 or higher, which is only about 12% of HCC patients, we switch those to them to mTOR-based immunosuppression after about a month. We don't know if that's the right thing to do, but that's what we do. All right, I think my time is up, but thank you.